just going to discuss what in the nuclear medicine we can do for those liver malignancies, and do we really have a good role in this? So we'll start by defining what are the liver malignancies, and we have the hepatocellular carcinoma as the main liver malignancy, the liver metastatic from the colorectal cancers, as well as other liver metastases. In my presentation here, I will be more directed towards the HCC. So why we are really going into this HCC? Because it's the third most common cause of cancer death all over the world. We have estimated about 1 million cases worldwide, and the median survival for this tumor is less than 4 months, and it's definitely under 1 year if we cannot treat those patients. Fortunately, we have a good sign that in the United States, in the last 2 decades, the survival rate from the HCC has doubled. And this is related to a better surgical resection and, of course, liver transplantations, which are very high effective treatment of patients with localized HCCs. The liver, as we all know, is a very amazing organ. It can regenerate. But if it's bombarded at different times, then it generates so rapidly into something what we know as cirrhosis. So before we go into any further, we heard from Dr. Alexander that the liver has a very peculiar vascular supply, with 80% of that coming from the portal venous system, while the hepatic artery, which gives the branch to the gallbladder, duodenum, the stomach, provides 20% of the rest of the normal liver blood supply. But when we have a tumor growth, this changes, and the main blood supply of the liver comes from the hepatic artery, and this is from 80 to 100%. So tumor vessel growth many times are concentrated in the periphery of the tumor as compared to the tumor center. And this will, as we go later on, we will see the implication of this differentiated blood supply. The liver consists of 3 lobes, including the caudate, 4 segments, and 8 areas. They are divided by the falciform ligament into anatomic left lobe, which is much smaller than the right. However, functionally, the left lobe is bigger than the right. So, for a quick introduction of the burden of HCC all over the world and in Egypt, the incidence of hepatocellular carcinoma in the United States has tripled over the last 2 decades. There are currently in the States around 3 million people with chronic hepatitis C and 1.2 million with chronic hepatitis B. And these patients are estimated to develop HCC at a rate of 0.5% to 5% per year. In Egypt, the number of deaths has risen from 4% in 1993 to 11% in 2009. And we estimate, this was in 2007, that at least 5 million Egyptian people are infected with hepatitis C virus. And the annual infection rate is around 17,000 new cases per year. So hepatitis C is a lethal virus which can cause liver cirrhosis and cancer. And Egypt, unfortunately, has one of the highest prevalences of this virus in the world. And we have an estimated 10 to 15% of the population, like 8 to 10 million people carrying hepatitis C virus. I found this very nice presentation of the magnitude of the liver cancer in Egypt by Dr. who is a professor of biostatistics in the National Cancer Institute, and was done in October 2003, showing us the magnitude of the HCC in Egypt at that time. And she found that the liver cancer is the 5th most frequent cancer site for males, after lung, prostate, stomach, and colorectal cancer, constitutes 7.5% of all cancer types, and in female it's 8%, 8th most common, accounting to 3.5%. So this is a presentation showing that in males in Gharbiya, where one of the most advanced cancer registries in Egypt is, lies second in males and lies fourth in females, And in the National Cancer Institute in 2001-2002, the liver malignancies constituted 44% of those of the digestive system, and it's on the rise from 1975 to 2002, as well as its mortality. When we went to mortality, liver became number one. So we have a very high problem with this liver malignancies in Egypt that we really have to tackle. A quick view of what we're going to do. We're going to diagnose this hepatocellular carcinoma. So we have tumor markers and we have imaging modalities. The imaging modalities will include ultrasound, CTs, MRI, angiography, and nuclear medicine. And as we see from all of those imaging modalities, meaning that one of them is not sufficient alone to describe the whole lesions. Tumor markers like alpha-fetoprotein has a very high specificity, but has a low sensitivity of around 50%, and we usually consider anything that is above 200 nanogram per deciliter highly suspicious of hepatocellular carcinoma. Ultrasound, of course, it's a first-line imaging modality, and its advantage is easy, fast access. However, its limitation, as always, will depend on the skill of the examiner. There are new ultrasound techniques that may help the ultrasonographer to reach a better diagnosis, and this is the B mode, where there is tissue harmonic imaging with echoes recorded with double frequencies, and flow-dependent techniques with color-coded duplex sonographies, so that we can see the perfusion in the metastasis with time. In the CT, it has developed dramatically over the last few years with the introduction of the multi-slice CT, and it gave us a very good imaging diagnostic tool with a tri-phase CT scan with no compromise to the temporal or the spatial resolution. So we have to do a proper tri-phase CT scan to reach for the proper diagnosis before either we go for chemoembolization, which is a TACE, or for radioembolization, which is a TARE. So we needed to get the best of the CT image, and this is done with this dual head power injector, where they will inject saline chasers after of 30 to 50 mLs after a contrast agent, allowing for a reduced contrast agent dose despite optimal contrast arterial phase. And these are the phases that the CT radiologist will diagnose the HCC using the early arterial phase, the late arterial phase, as well as the portal venous phase. And from that you can see the enhancement seen in these tumors, and these will be reflected to the diagnosis. MRI is going into a very strong position, being a standard procedure in abdominal and liver imaging. And among other factors, the development of 3D consequences, respiratory triggering, and parallel imaging have important contribution to the diagnosis of hepatocellular carcinomas. Pure angiographies have really declined over the years, and it's only restricted to special indications, just as a preliminary diagnosis for liver tumors. And the basic for this is that it relies with the diagnostic evaluation of the liver tumors with strong vascularity, as we have described before. It's now replaced with CT angio, in which we can see the arterial supply coming out of the common hepatic artery. We can see the left gastric artery as well as the splenic artery in these CT angiograms. We can also see the aberrant replaced right hepatic artery and the aberrant accessory left hepatic artery coming out of the left gastric artery. As Dr. Alexander, all of these arteries have to be coiled before we proceed into any effective treatment for liver malignancies. And It's also been said that the anatomy of the mesenteric system as well as the hepatic arterial bed have a very high degree of variation. And we can see so many variants coming out of the left gastric arteries, of the left hepatic arteries, and all of them have to be documented, coiled before the beginning of the treatment. A parasitic supply coming out from the omental artery and giving its blood supply to the tumor itself. And whenever we try to treat this tumor, it will get more blood supply from the parasitic artery, and we will not be able to close the arterial parts, the artery of this tumor, and the tumor will survive. So, what is the role of nuclear medicine? First is the treatment planning and patient selection, shunt evaluation, predicting toxicity, possible PET-CTs. We can treatment monitoring, treatment evaluation, and the treatment, which is the local regional, which is our subject today. So, before we embark on therapy, we have to adequately plan this treatment. We usually take the combination of morphological imaging like the CT and MRI, functional imaging, PET-CT and SPECT-CT into our account before we try to treat any of those patients. And we have said that the selective intraarterial treatment achieves very high radiation doses within the malignant lesions while reducing the radiation exposure to the normal liver parenchyma. And to predict the radiosphere treatment toxicity, we must know the lodging of the radioactive microspheres in the non-tumoral hepatic tissue before we give the treatment. And determine, of course, possible lung damage due to liver to lung shunting, like Professor Alexander has told us. So, it's a very tricky where we put our catheter. Are we going to put it in the hepatic artery, the right hepatic artery? Are we going to put it in the common? Are we going to put it in the left? And this will all depend on what we are going to achieve, and this will need sometimes more than one setting just to be sure that we are in the right position. So, bilateral lesions, we can see first in the angiography, but when we injected in the common hepatic, we only saw the right hepatic artery, the right lobe. So we had to selectively, in the second time, select the left hepatic artery in order to reach the left hepatic lobe. Shunt evaluation, as has been discussed, is very important before we start any kind of treatment. So to either reduce the dose of the treatment for the liver, or if it's more than 20%, usually it is not administered. And this is the same image Dr. Alexander has shown us. It's very diagrammatic of exactly what we're going to do to calculate the lung shunt. How to predict toxicities? Like we have said before, that any extra tumoral uptake is liable for complications. So if we are seeing gastric mucosa, taking care, of course, that it's not technetium, this will cause toxicity in this area. Gallbladder, cystic artery, like Dr. Alexander has shown us, yes, again, it may cause toxic effect in the gallbladder. Any perfect match among the tumor nodule seen in the CT and SPECT-CT of the MAE injected will have a high predictive value of response. This is one of the cases in which there is a very big mass in the liver by the CT, but when we injected the MAE, it only appeared in part of this mass. Later on, when we followed it up, we found that only this part has improved from the whole tumor mass. So we can predict our response just based on the MAE scan. PET-CT has very high sensitivity in detecting malignant lesions. And negative predictive value PET has already been established in its staging and monitoring of therapy response. But we have a false positive results that has been described in inflammatory disease. So FDG uptake is not very cancer specific. And the SUV again is, although it's established method for reliably quantifying the tumor glucose uptake, but especially in HCCs we have a very different expression of the enzyme that may lead that this tumor will not take up the FDG. So FDG in HCC is not a predictive value, and it has to be done on a patient-by-patient basis. Other new PET traces like the carbon evidence state might be closing this gap and will differentiate SCC lesion with very high sensitivity. In treatment monitoring, nuclear medicine really plays no role, and the main role will reside with the CT after the treatment. However, accidental extrahepatic spread of microspheres can also be visualized on the post-therapy images. Since, as we have said also before, the E-terminality is a pure beta emission. So we will not be able to image X-rays except through the brim shrouding. And this can be done either on a SPECT CT, or recently we are working even on imaging them on a PET CT. The treatment evaluation, like you can see that this is the patient who has received, he was a positive for PET CT. He has received liver treatment, and over time, which is around 1 year, the whole liver returned back to normal activity. Again, another response before treatment with multiple hepatic nodules, okay, positive on PET CTs, and then they are disappeared. One of the main ideas that we also have to take care of, that it is not just the liver malignancy that we have to look for, but we have to look again for the general liver condition. And sometimes we treat the tumor, but the liver condition gets worse. So we have to take care of this. And there are a lot of classification now that have been advised by a lot of committees like the child book classification, like the Barcelona group. A lot of classification has been put just to categorize patients, where they're going for transplantation, where they're going to go for chemotherapy, and where they're going to go for local regional management. Staging, again, is very important, and as a lot of people are using now the American Joint Committee on Cancer and the Barcelona group for their staging. So we have now reached to management. What we're going to do for those patients? We have diagnosed them. We know the magnitude of the problem, purposes, or to downgrade into a resectable liver mass or a transplantation liver mass. So the non-surgical management will include no management if the patient is in very bad shape, chemotherapy, radiofrequency ablation, external beam radiation, transarterial chemoembolization, and transarterial radioembolization. And we have seen the systemic chemotherapy with no real effects on the survival of the patients, 10.7 months as regards 7.9 months for placebos. Radiofrequency ablation is acceptable, but it has certain criteria that we have to observe before going for that. Transarterial chemoembolization, transarterial radioembolization are a growing field in this direction. So these are the indications for radioembolization. No surgical option, no thermal ablative therapy possible, standard chemotherapies are without success. We have a preserved liver function and good Karnofsky index and good ECOG index, performance index should be there. Dosimetry and dose calculations, we know that there are two components, the dosing ray and the activity in gigabecquerels that have to be delivered to the patient. And why we selected this yttrium, because of its favorable properties, which is a pure beta emitter, has an average beta emission, average penetration inside the tissues with a reasonable physical half-life of 64 hours. We have two available microspheres for medical use. Although they differ in significant ways, the two available microspheres have been shown to be equally effective in variety of solid tumor types. There are the SEER spheres, okay, and this is coming from an Australian group, and the Thera spheres, and this is coming from the Northern Ontario, Canada. And they have a little bit differences regarding their diameters, their specific gravities, activity per particle, and the number of microspheres in the treatment dose and the material itself. The glass microspheres, it has very high activity microspheres. It reaches 2,500 becquerels per sphere, and it's usually delivered in preset activities and ranging from 3 to 20 gigabecquerels. The target dose for the glass microspheres is between 100 and 150 grays, and the appropriate volume and mass, either the whole liver or a single lobe, are determined using the CT or the MRI, and using this as to calculate the activity as one way of the method that is given either the activity required and the liver dose from this. The written microspheres have a less activity, which is around 50 becquerels per sphere, and some of the people would have experienced temporary embolic side effects because we had to increase the number of particles, and the method to estimate the activity is usually based, like Dr. Alexander said, BSA methods, empiric methods, and partition methods. When we compared this post-embolization syndrome for TACE with our TARE, we found that there's a lot of patients suffered from pain following the TACE because of the high embolic effect of that. 69% of TACE patients versus 18% of glass radioembolization patients had post-embolization syndromes, and the yttrium-90 glass embolization offered low toxicity profile with minimal complications. So just to show you a few cases of improvement, you can see this huge liver mass before injection of TheraSphere and after the injection of TheraSpheres. This downgraded this liver mass and now can be thought of possible other modalities for treatment. Again, another very large lesion in the right hepatic lobe, which decreased over time to a very smaller lesion. And a very huge mass in the right lobe that has reduced after 2 months and has with very minimal residual after 8 months. One of the most intensively working group on these treatment for liver is a group from Hammersmith headed by Dr. Adel Nahas. And what I would like in this, that they have 8 deaths recorded in the 40-month period out of the whole group, which is around 41 patients, and they have something like a 4-year survival rate. So this is a very novel treatment, still in its beginning, and I think with time we will get more and more into the treatment of liver malignancies using the radioembolization. Thank you for your time.
Thank you, Dr. Ashraf, for this nice, informative